All right. Hi, everyone. Welcome to the National Fellow Online Lecture Series. Our lecture topic today is MRI Series Hip and Knee. My name is Dana Sheng. I'm a sports medicine physician at Dignity Health, and I'll be your moderator for today. Next slide. This lecture series is sponsored by the AMSSM Online Fellows Education Subcommittee, co-sponsored by the Education Committee and the Fellowship Committee. Before we get into tonight's talk, I want to remind everyone of the lecture next week on sports pulmonology with Dr. Andy Getson. Next slide. The goal of this lecture series is to serve as an adjunct to your individual fellowship program education and to provide sports medicine fellows with direct access to learning from experienced MSSM members and invited guest speakers in a variety of formats. Finally, this is also meant to assist in CAQ exam preparation. Next slide. Some reminders, make sure to mute your microphone, turn off your video. You can submit questions at any time through the chat function. At the end of the talk, I, as the moderator, will ask the questions during the Q&A based on the questions you submit. And after the program, we would love your feedback. There are a couple ways to do this. First, a web link can be found by going to amsssm.org, click the Education tab, then select Fellow Online Lecture Series. The link is near the top of the page as seen in the screenshot. And the second way, maybe next slide, is by scanning this QR code. It should take you directly to the form to fill out. When filling out the form, we ask that you please keep in mind the primary goal of this series is to assist in CAQ preparation for fellows. And now I'd like to introduce you to our expert speaker today, Dr. Navid Faraji. Dr. Faraji is a musculoskeletal radiologist and the Associate Division Chief of MSK Imaging at University Hospitals Cleveland Medical Center. He also serves as the Associate Program Director of the Diagnostic Radiology Residency Program and the Director of Medical Education in the Department of Radiology at UH Cleveland. As an assistant professor in MSK Radiology and Anatomy at Case Western School of Medicine, he's passionate about medical education and enjoys engaging medical students and residents in radiology research. In his free time, he enjoys playing ultimate frisbee, hanging out with his wife, cats, and dog. And you can find him also on X at SportsRadDoc. Catch some interesting cases on there as well. And with that, welcome, Dr. Faraji. Thanks so much for being here.
Thank you. Thank you, Dana, and thanks to sports medicine folks for inviting me. So let's get this party started yet. We're gonna go through hip and knee imaging today. It's a lot to get through, so we're gonna keep the pace up, but I hope it will still be intelligible and not too rapid. But keep track of any questions and we'll get to them hopefully at the end. Okay, so first let's just talk about MRI as a modality. MRI, we get to see bone marrow edema, right? So we get to see the tissue characteristics of the bone marrow. And so what we might miss on X-ray or CT becomes a lot more conspicuous on MRI because we can see bright bone marrow signal on various sequences, which tells us that that bone marrow is not happy, it's edematous, and we can see those findings. We're not relying solely on cortical disruption or fracture deformities to see our abnormalities. And MSK imaging, CT is more limited, as you folks know, mostly done in the setting of known fractures for pre-surgical planning or in the setting of maybe like X-rays were negative, but MR is not available, and we just want to see if there's like some fracture that we might be missing. CT is good for that. So, but really, X-ray is the mainstay of musculoskeletal imaging, and then MR would be our next best test in many cases. And today we're going to concentrate on MR because that's what I'm told we're here to do. So let's do it. All right, let's start with the hip. So we have in MSK radiology, we have various ways to image various joints for various indications. Okay, so if you order a hip MR, you may get it with like an FAI protocol is how we call it at my institution, or you can get it for what we call our fracture AVN protocol. And those are two different like patient populations, basically. So this FAI protocol, you can see here the thing it has is a small field of view of the hip joint. And that's super important because in an MR, when you have a smaller field of view, your spatial resolution is much better. So we can see things like labral tears or cartilage abnormalities more conspicuously on a smaller field of view than we can on a large field of view. So usually if the indication is labral tear or FAI and appropriate patient population, usually around like 40 or under, that may get surgery for labral pathology, then we usually do the FAI protocol. In older patients, we do this other protocol. So there's no small field of view really. We're going to do mostly, am I sharing? Let me share. Hold on. I am sharing, right? Okay. Just tripping here. Four. In adult patients that are like 50 or older, and we're not talking about labral stuff, we're going to do this MR bone fracture AVN. And we're going to see some images, and so you can see the varying, the differences between them. But here we're going to catch the contralateral hip. We're going to catch like the osseous structures of the pelvis, things going on inside the pelvis. So we're more likely to catch incidental findings on this protocol on the right than we are on this protocol on the left. And it's just much more likely that these older patients are going to have important incidentals and contralateral hip pathology than it is in this younger patient population. Real quick, we'll talk about sequences. All right, so you got to know what you're looking at in order to figure out what the pathology is. You have to know what sequence you're looking at, and so it's really important that you kind of find some fluid on your images and say, hey, is fluid bright or is fluid dark? And we can see here on this image on the left that we see the littlest bit of joint fluid, and that tells us that this is a fluid sensitive or a T2 sequence. Fat is dark. And we've done these are technically proton density, which similar to T2 in many ways, but they're more like in the middle between T1 and T2. But then the main thing here is that we did physics magic to nullify fat signal intensity. That's called fat suppression. That's what the FS stands for. So when everything's dark, if a tissue is infiltrated by fluid or edematous, like bone marrow edema in the setting of a fracture or a contusion, or soft tissue edema in the setting of a soft tissue contusion, you're going to see that conspicuously as bright signal in a background of dark signal. So this physics magic that we employ in the name of fat suppression is super important to draw our eyes to abnormalities. The non-fat suppressed proton density is also useful, less useful for finding the pathology, but more useful for characterizing the pathology. We can see the articular cartilage pretty nicely. So proton density sequences have really good signal to noise ratio, allow us to identify articular cartilage or fibrocartilage pathology like the menisci. So we use them in combination. Anytime I'm looking at MRs, I'm looking at two sequences side by side, vast majority of the time. So this is a knee, obviously. But we use these sequences in all different anatomic parts of the musculoskeletal system. So these are proton density fat suppressed on the left and proton density non-fat suppressed on the right. The only other two sequences I want you to know about are the T2FS. So this is a T2 fat suppressed. It looks very similar to proton density fat suppressed. It's just a little bit more fluid weighted. So fluid is a lot brighter in this. And then on the right, we have a T1. And these are really important for looking for infection, or if we're characterizing a bone tumor or neoplasm, you got to have these. The proton densities don't do anything for us for tissue characterization. They help us to figure out, like, look for fibrocartilage pathology, like meniscal tears or articular cartilage pathology, but they don't tell us if somebody has a liposarcoma or some bone tumor or something like that. These are the mainstays for those things. In reality, all of our protocols have all of these different sequences and some combinations, so we can do all of the things that I just described. What I would say is, again, fluid is bright, fat is dark. If you see in those sequences, look for bright stuff because the chances are the bright things are abnormal, or hyper intense things if we want to use the correct terminology. And then on the dark one, it's the brighter one, it's better for anatomy. You have better fat planes between muscles and between tendons and stuff like that. You can see bone marrow as fatty in adults. As we know, adults have yellow marrow or fatty marrow, so we want to see normal fatty bone marrow on these. So these are good, and we use them in combination. So we're going to go through some sequences here, and I'm going to do it like I do it in real life. All right. And we're going to go through search patterns and normal anatomy. All right. So a few things you're going to want to know here is that one, we see fat here as super bright. We see fat as dark here because we've suppressed the fat. We see CSF here in the central canal as bright. We see it as dark here. So this is a T1 weighted sequence. Fluid is being dark. This is fat suppressed T2 where fluid is bright. Okay. And And tendons, no matter what you're looking at, no matter what sequence you look at, tendons are supposed to be dark or hypointense, okay? So if a tendon is brighter or like grayer and not just black, that generally indicates that that tendon is pathologic, whether it's bright because it's tendinosis or if it's bright because it's torn, or both. But we're looking for dark tendons to be bright. That's pathology, okay? If it's fluid bright, that means that tendon has been disrupted by fluid and is a tear. And if it's just kind of gray, then it's probably not torn, but it's tendinosis. So let's just look here at some anatomy. We're going to go down. Let's see here. So I'm going to just slice where these are axials, obviously, and I want to get to this critical slice. So here we have our three gluteal muscles, minimus, medius, maximus. You can see why the T1s are so nice. You see the thin fat planes separating these muscles, whereas on the fat suppressed T2s, I can't really see much differentiation of those muscles. I kind of have to hallucinate it. So the differentiation of muscular anatomy is much better on the T1 non-fat suppressed sequences. And then as we go down, you're going to see that these muscles start to form tendons. Okay, so here's the tendon of the gluteus medius, and then pretty soon we're going to see the tendon of the gluteus minimus. And like, so when I'm looking at these, I'm just following these tendons down to their insertions. And so let me do that here. So here's the gluteus medius tendon. You can see it here bilaterally. And the gluteus medius tendon, we know, inserts onto the more posterior facet of the greater choke. And so here's the greater choke. Here's that gluteus medius inserting there. Similarly, here's that gluteus minimus tendon. It's hypointense black, inserting onto the more anterior facet of the greater choke. So I'm just going through that pattern and seeing if they're normal and low signal intensity, then that's great. If they're a little bit gray, then maybe there's some tendinosis. If they're frankly disrupted by fluid, you can see fluid is bright here, then that's a tear. And we're going to talk about varying degrees of tear. We can see that this, for example, we talked about T2s showing us pathology. We can see this femoral head is really bright and this femoral head is really dark. So this is normal. And this is abnormal. This is bright because the bone marrow has been infiltrated by fluid, right? That's, edema or bone marrow edema or soft tissue edema. It's just infiltration of any tissue by fluid. And that tells us that that is abnormal, okay? And we have to use both of these sequences in multiple planes to characterize that further. So this is kind of what the axials will look like. And this is that, fracture AVN protocol. We can see we have full field axials. We'll see the prostate, we'll see the rectum, we'll see it for any incidental findings. So not really getting a good look at the labrum on these large field of view images. So it's very limited in that regard. But we are getting a good look at the bone marrow. We're getting look for joint effusions, any tendinous pathology. And so I just did the glutes. You can do the rest. Here's like the iliopsoas tendon that's going to insert onto the lesser troch as we go down here. Here it comes, here it comes, here it comes, and it's inserting onto the lesser choke. Hamstrings we see originating from the ischial tuberosities bilaterally. Again, normal. So, I won't go through all of the anatomy because we got limited time, but you know all the tendon origins and insertions. You should know them from the pelvis and hips, and you're going to be looking for black or low signal intensity structures originating or inserting onto those structures. And if varying degrees of bright signal, particularly on these darker sequences, the fat suppressed sequences will tell you if there's pathology. Similar situation, different plane. Okay, so here's the coronals, and I promise we're going to get to the meat of the talk here. One thing I just want to point out is that the T1s are also really good for looking at nerves. I mean, you can see the sciatic nerves kind of coming out of the sacrosciatic notch here. Again, really good for looking at just normal bone marrow. Bone marrow should be bright in adults. We know it's fatty. And let's talk about pathology while we're here. So same patient, coronal plane now, and we can see that there's bone marrow edema or bright hyperintense signal, the femoral head and neck. We see there's a little bit more joint fluid on this right side than there is on the left, so we know that there's a joint effusion. And the pathology is here. We see that there's this kind of serpiginous, hypointense or low signal intensity line. And you can kind of see here what we call in MSK the double line sign. So you can see that there's a bright line here next to what we saw, that dark line on the other side, that's the double line sign. And the double line sign is a great sign for avascular necrosis. So this is a patient with right femoral head avascular necrosis. We can see how spherical the left femoral head is. The right femoral head is less spherical, so we're having articular surface collapse of the right femoral head, which can be a something that avascular necrosis can progress to. And so we'll go on to the next slide just for the sake of time. So we talked about this protocol. We have coronals and axials in a large field of view. Oh God, forgot to mute this one. Okay, we do get a sagittal of the affected hip in this protocol. So one thing I want to just real quick talk about, same patient. Again, you see our double line sign here of avascular necrosis, and we do get a little bit of labrum here. So the labrum is made of fibrocartilage. It should be hypointense or low signal intensity triangle. And it's kind of gray here. This patient probably has some degenerative labral tearing, but there's no linear signal within it to suggest a definite, like, acute traumatic labral tear. The other thing I want to point out to you is this gray stuff. Okay, so you see this black line or hypointense line. That is the subchondral bone of the femoral head. And this gray or intermediate signal intensity stuff on both of these sequences between the femoral head and the acetabulum, that's our articular cartilage. So for me, when I'm looking at any joint, I expect to see gray on the surface of the bone. If I've done it enough times that I know if I'm seeing a bunch of fluid or more fluid than I'm used to seeing in the joint surfaces, that to me is an indirect sign that there's less cartilage than there should be, and then the fluid is filling that space. So it's a sign that there's articular cartilage loss, whether it's a full thickness defect or a moderate grade defect, but you're looking for that intermediate signal intensity cartilage. Okay, let's go to the next one. So here's a bunch of diagnoses we can see on MR around the hip, AVN, which we just saw, bone marrow edema, which we kind of just saw in a different setting. We talked a bit about tendinous disorder, so we're going to see some more concrete examples of that. Athletic pubalgia or sports hernias, muscle injuries, fractures, FAI, which we'll talk about a bit, and developmental dysplasia of the hip and hip preservation type stuff, piriformis syndrome, arthritis, and tumors. So here's a question for you. I'll let you guys read it, and I don't know if you just want to answer to yourself or you can type it in the box, whatever you want to do. So, which of the following is the most likely diagnosis? Limited hip. Okay, so 26-year-old male soccer player, gradually worsening groin pain, worsened by sprinting, cutting, prolonged sitting on exam, limited flexion, and internal rotation. Here's the radiographs. So is it CAM type, FAI, pincer type, hip dysplasia, osteitis pubis, or AVN? So the answer is coming here in 3, 2, 1. Okay, so this is a patient on the left. I think we have kind of a mixed. It's probably both of these a little bit, but it's more CAM. So this done lateral view of the left hip is kind of showing you that there is excess bone at the femoral head neck junction. So the femoral head should look like a golf ball sitting on a tee. And then tees, they're like widest at the top and then they kind of get narrow. And we should be seeing here a concave contour of the femoral neck, but we see that it's actually convex, which means they have this cam type or pistol grip deformity. You can kind of hallucinate like this is the grip of the pistol, and then the rest of the pistol or the barrel would be down here, and that's our cam type morphology. Now, what we also see here on these axials too, or these AP radiographs, is that we have our femoral crossover sign. Here's the posterior wall of the acetabulum, which is crossing over the anterior wall. And that's showing us, I'm talking too fast. This is the anterior wall crossing over the posterior wall. Okay, so this is our acetabular retroversion or crossover sign. And that tells us that at any point when the anterior wall of the acetabulum comes out further than the posterior wall, that is called acetabular retroversion. And it's a sign of a pincer type morphology. So this patient and most patients do have a mixed type femoroacetabular impingement. This person does have a here's a cam, and then we saw that pincer type with the superior acetabular retroversion there. So let's talk about the other protocol. So this is what a small field of view of the hip looks like. Okay, we get a lot better spatial resolution. This is a T2 fat suppressed sequence. We can see that we see the intermediate signal intensity of the articular cartilage pretty well here, and we can differentiate that from joint fluid. And then here's the labrum, the superior labrum, and you can see nicely here that there is fluid signal intensity disrupting this black or hypointense structure. So the labrum is made of fibrocartilage. It's highly organized, and that generally on MR structures like that don't give a lot of signal. Similarly, tendons are highly collagenated and organized. They don't give a lot of signal. So these things that should be black or hypointense when they're infiltrated by fluid or they have linear fluid signal intensity disrupting them, that's indicative of an issue. And in this case, it's a labral tear. We can see here articular cartilage of the femoral head and acetabulum, and then we can see here this arrow sign, positive arrow sign, is pointing to like an area of full thickness articular cartilage loss. This is kind of what I was alluding to, where you see too much fluid where there should be more gray. So this is a patient again with FAI. That's what the labral tear looks like. And here's some more tendons you can see inserting onto the greater and lesser trochanteric hamstrings originating from the ischial tuberosities. But just wanted to give you an example of how much more spatial resolution and kind of anatomic detail we have on these smaller field of view hips. Here's the same patient and the axial plane. And we're going to talk a little bit about that, what we're looking for here. We can see cartilage nicely. Let me pause. We see the articular cartilage, and then we also see this cam type morphology. Again, femoral head should be a golf ball sitting on a tee. This has a big chunk of bone here, thicky femoral neck anteriorly, and that's no bueno. That's a really significant cam type morphology. And we're going to talk about how we quantify that with what's called the alpha angle. So real quick, FAI, again, it's a pathology basically where there's anatomic variation either of the femoral head or the acetabulum or both, in which there's excess bone formation. That excess bone formation can cause chronic repetitive microtrauma, and labral tearing, continued micromotion can cause premature accelerated articular cartilage loss and osteoarthritis. So we talked about normal. Here's what the cam looked like with excess bone there. The pincer is when there's excess bone of the acetabulum, and then mixed, which I kind of alluded to, is a combination of both of those things. And that's what, we're looking for these morphologic findings. Now, it's really important to know that just because the patient has the anatomy doesn't mean they have the pathology. So you definitely have to correlate with your physical examination, whether they have positive impingement tests and restricted internal rotation and flexion and things like that. So, we're going to rely on you to diagnose the patient with the clinical syndrome. We can only assess for the anatomic and morphologic abnormalities. Radiographically, this is how you measure an alpha angle. You draw a best fit circle to the femoral head. You draw one line down the shaft or the neck of the femur, and then you draw the other line where the femoral cortex starts to deviate from your best fit circle. And the angle between these two lines is the alpha angle. A little bit about exam ordering, which may be potentially in your test. So when we're looking for labral pathology in the hip or the shoulder, really at this point, conventionally, historically speaking, 1.5 Tesla MR arthrograms has been the best test. Okay, so 1.5 Tesla is just a unit of magnetic field strength. The more Tesla you have, the better the images are. Generally speaking, you have better signal to noise ratio. MR arthrography is when we inject the shoulder or hip with contrast. And so 1.5 Tesla MR arthrography is really good for diagnosing labral tears. But some studies have shown that 3T non-arthrographic MRI is equivalent to a 1.5T MRA. So depending on your patient population, depending on what you have available to you in your system, I would say 3T MRI or 1.5T MRA for labral pathology are non inferior to each other. For cartilage defects, 3T MRI is a little bit better than 1.5T MRA. And for cartilage delamination, again, they are non-inferior. So the moral of the story, I think the takeaway here is if you have access to a 3T MR, you can save your patient a little bit of trauma and by getting that, and they don't have to get an MR arthrography. On MRI, here's how we do the alpha angle. Similarly, we just draw a best fit circle to the femoral head. We draw a line down the shaft and then the neck of the femur, and then our second line is where the femoral head starts to deviate. You can see the angle here is 77. That's abnormal. Anything above 55 is abnormal. Here it's 52, and this is normal. So we can see here, obviously, there's a little bit of excess bone here at the anterior femoral head neck junction, whereas here it looks relatively nicely like a ball sitting on the T. Here's a couple more images of a labral tear where we see a fluid signal or intermediate signal intensity defect undermining the base of the labrum. So this is more of a labral detachment or a chondrolabral junction tear is another way to say that. So we saw a case of AVN, just real quick, let's run through some common causes, but we know hemoglobinopathies, chronic corticosteroid use, trauma, uh, especially in the setting of femoral neck fractures, lupus, alcoholism, pancreatitis, I don't know if they test you guys on these, but they definitely test on the radiology boards various causes of AVN. And again, another example of the double line sign where we see a hyperintense or bright line next to a hypointense or dark line, and that's indicative of vascular necrosis. There's no collapse of the subchondral bone plate. There's no bone marrow edema, so this may be asymptomatic in this patient. Here's how that looks on the coronal plane in a relatively motiony examination. The left hip has some hardware, and we can see the artifact that's causal. Okay, let's talk quickly about hip tendon pathology. So hopefully you can see with relatively conspicuously how crappy this MR image is relative to some of the other ones we've been seeing. Probably a low field strength, low Tesla MRI from back in the day, or even some of these outpatient standalone orthopedic centers now have like, 0.3 Tesla MRIs, but they only charge the patient a couple $100 out of pocket rather than like $1,000 out of their insurance plan. So sometimes you're going to get these, unfortunately. But I guess the point of this case is that we see fluid signal intensity here on the left, adjacent to the greater trochanter, which can be seen in the setting of trochanteric bursitis, which commonly goes hand in hand with abductor, abductor pathology, gluteus minimus or medius tendon pathology or tears. So you'd want to scrutinize those things. Um, Other tendon pathology we can talk about are the adductors and setting of athletic pubalgia. And we talked a little bit already about gluteal tendinopathy being the most common injury about the hip. Here we can see, okay, so I'm going to make this anatomy make sense to you. This is the anterior facet of the greater choke. Here's the posterior facet. That's not actually what they're called. There's like posterior superior facet, but for me, it's like a lot easier just to call it anterior and posterior, just as an FYI. We can see fluid adjacent to the greater chokes, and we don't see any tendon here. There should be a black or hypointense tendon inserting, and these arrows are pointing at the relative absence of tendon, indicating tendon tearing. We can see on this coronal plane that there's some bright signal intensity here at the insertion of the gluteus medius tendon, which likely suggests a degree of tendinosis with possible intersubstance tearing. You just have to ask yourself, is this brighter? Is this just as bright as joint fluid? I don't have any joint fluid on this image to compare, but if it is just as bright, then that's probably indicative of a tear. If it's not as bright, but still brighter than black, that's probably tendinosis. And varying degrees of thickness, it's kind of a gestalt thing. There's no like grading scale for tendinosis that I use. It's just how thick is it compared to what I normally see, and how gray is it or bright is it compared to what I normally see. Similarly, here's a normal gluteus medius tendon, very, very low signal intensity. And then on this non-fat suppressed proton density, we begin to see a little bit of bright signal indicative of bursitis. And we can see here's a low signal intensity tendon, which is kind of partially disrupted in this area by this intermediate and bright fluid signal. So this is a partial gluteus minimus tendon tear because we see it's on the anterior facet of the greater choke with some resulting or corresponding choke bursitis. Okay, so again, frequent coexistence of these two things, tear, tendinosis, and bursitis. Okay, and let's real quick talk about athletic pubalgia. So, athletic pubalgia or sports hernia, we know, is a pathology related to the adductor tendon and rectus abdominis aponeurosis. So, those two muscle groups have a common aponeurosis, which is just like a fibrous band of tissue that attaches or originates or inserts to the pubic symphysis. Okay. And people like running backs or folks that are doing a lot of cutting or change in direction, sometimes there's some instability between those muscle groups, and that can cause micromotion of the pubic symphysis and what we call osteitis pubis, and then also it can cause stripping of the aponeurosis, which is what we call athletic pubalgia. So let's talk about that. So here we can see this is what we would call osteitis pubis, in that we see some resorptive change, irregularity of the pubic symphysis. This is a coronal, by the way, so we're just like slicing front to back in the AP direction of through the pubic symphysis, and it should be a nice black line or hypointense line, but we see it's frayed and irregular. That is that is osteitis pubis. We don't see any fluid signal intensity undermining these low signal intensity fibrous structures like we do here, for example. This is crescentic fluid signal intensity, which is suggestive of aponeurotic stripping of the common aponeurosis of the adductors and rectus abdominis from the pubic symphysis. And again, this would be athletic pubalgia. This would be osteitis pubis. Lastly, another case just showing a little bit of fluid signal intensity. So in this athletic pubalgia protocol, we have these really coned down views that give us better spatial resolution, but you can see nicely here as well that there's some fluid signal intensity there. So that's kind of what we're looking for in those two cases, and just a little bit more information about that. And it can be frequently bilateral, and again, usually in sports where there's a lot of change in direction. Let's talk about muscle pathology. So this can be extrapolated to anywhere, but muscles, tendons, and ligaments, we kind of grade them all the same as far as degrees of injury, grade 1, grade 2, or grade 3. This is sports, so we're going to talk about strains, but you should know that obviously rhabdo and your can happen in your long distance runners and things like that, which will look like diffuse muscular edema. There's some delayed onset muscle soreness, which is not necessarily pathologic. It's just a muscular reaction to activity. It can result in soreness a couple days later, and then muscle contusions, hematomas, and myositis ossificans. So let's talk about muscle strains. Grade 1 strains, we talk about muscle like feathery intramuscular edema. This is a feather. We can see nice bright signal between these little myofibrils, and this is what a grade 1 strain would look like. We don't see any architectural disruption. We don't see a focal hematoma. We don't see full thickness disruption of any of these fibers. We don't see any fibers disrupted, just some edema between those things. That's what we would call a feathery pattern grade 1 strain. Grade 2, in contrast, is where you have the feathery edema, but in addition to that, you have areas of partial disruption of a muscle group. So here's your biceps femoris muscle. One, we see a lot of epimysial or intermuscular fascial edema. And then we can see here on this anterior compartment, rectus femoris, that there is like a chunk of muscle that's missing here. And so this is partial discontinuity of this muscle group along with the muscular edema. So we would call this as a grade 2 strain. Lastly, the hamstring is basically torn and avulsed or all the way down here, and there's a big gap of fluid between the tendon and the retracted muscle. This is a grade 3, which is a complete disruption or avulsion of the muscle or myotendinous junction or origin. So that's how we grade those. Ligaments, similarly, if just perimuscular or periligamentous edema is grade 1. If there's partial disruption, grade 2, and if it's fully disrupted, grade 3. Lastly, for MR, it can really help us identify occult fractures. Here, you'd be hard pressed to see this fracture on the radiographs, but on the MR, on the T1 sequence, we can see nicely a little fracture line there. So much more sensitive to fractures on MR relative to CT and X-ray. And here's what that looks like on the T2, where we see the muscular edema, we see the adjacent soft tissue edema, and the T1 is really good for depicting that fracture line. And then another thing that is commonly being done now is to look for intertrochanteric extension of fracture. So on a radiograph, this looks like an isolated greater choke fracture, which is treated conservatively, but we want to see if there's any intertrochanteric extension. So commonly our colleagues in orthopedics and sports medicine will get an MR to look for intertrochanteric extension because that makes this a surgical case. And we can see here now that there's this kind of jagged T1 low signal intensity fracture line extending from our greater choke fracture into the intertrochanteric region. Stress fractures, we're going to see bright bone marrow. Again, the bone marrow is not happy. It's usually medial femoral neck, and we see this jagged fracture line. You can have stress reactions where you don't have a fracture line, but you just have the edema. The more edema you have on T2, the brighter the T2, the higher degree of the stress reaction, and the lower the T1, you want to look at the T1 too. So if it's just bright on T2 but normal on T1, that's kind of like a mild stress reaction. If it's bright on T2 and low on T1, that's a more pronounced stress reaction. And then when you start to have intracortical signal abnormality or fracture lines, that's the highest grade of stress reaction. Um, so you want to look at the T2 in addition to the T1 to kind of grade your return to play. This all has like a bearing on return to play. So if you have a fracture line, it's going to be the higher end of return to play. It's going to take longer. If it's just bright on T2 but no T1 signal, then it's on the lower end. But if it's bright on T2 and low on T1 but no fracture line, that's kind of intermediate. So you want to look at all the images you have. So here we can see that what that low T1 signal looks like, and then you can see the fracture line there as well. Similar patient, contra a different side, we see the bright T2 signal. We don't necessarily see a fracture line there. Okay, 9:30 I think this thing goes till. Hopefully, just tell me if I'm wrong. But let's run through the knee. So I'm not going to go through these again, but hopefully you remember fluid's bright, and these are our proton densities. Fat suppressed on the left, non-fat suppressed on the right, again, and we use them in combination. So let's do some anatomy. So when I'm doing knees, I go from lateral to medial in the sagittal plane. And again, dark things are tendons or ligaments usually. We can see the hypointense tendon first thing inserting onto the fibular head, okay? You see this kind of these strands, these striations, these are superficial to the femoral head. That's your I keep saying femoral head. So your fibular head, and that's the peroneal nerve, okay, coursing superficial. We're seeing this black thing. You can probably guess that is your lateral collateral ligament or fibular collateral ligament that we're slicing through right there. And then we're kind of here, we're slicing through our IT band, which is inserting onto Gerdy's tubercle on your tibia. We're starting to see a little bit of lateral meniscus body segment. Again, menisci should be really dark. They should be biconcave. If we're looking at the anterior horn and posterior horn, we shouldn't see any fluid signal intensity disrupting those menisci. And so that looks good so far. Here we're going to see the ACL. We're going to see the PCL. And then we should see the medial meniscus posterior horn and root. Posterior horn, we're going to keep going, and then we're going to get to the body segment. I want to show you some cartilage stuff. So look at the cartilage on the second time through, and we can see that the cartilage again is this gray or intermediate signal intensity stuff on top of the bone or superficial surface of the bone. Ooh, I messed it up. Okay, hold on. Come on. Oh God, I hate myself. Okay, let me show you this. This is the image I want to show you. Here it is. So we can see cartilage, cartilage, cartilage right up against the low signal or a black line there. Here we see this thin, bright line deep to the cartilage. That's cartilage delamination. And that's like this cartilage is basically just hanging on to the bone. It can shear off at any moment. So we want to describe that. Here's the quad tendon. Here's the patellar tendon. That all looks pretty good. So no major pathology of the ligaments or tendons in this particular case. That was a sag plane. Let's look in the coronal plane. This is fat suppressed, so we can see everything's darker. We see the posterior horns of our menisci bilaterally, and we're going to just slice through that as we go. We see our MCL here, this black or hypointense structure. We see a little bit of LCL there. We can see some nice bone marrow edema of our lateral femoral condyle, again, indicating the presence of pathology. And you also want to watch your ACL and your PCL in the coronal plane. Sometimes the sagittal plane will look normal, so you want to follow your ACL, which you know originates or proximal attachment is your lateral femoral condyle inner aspect, and it's going to go towards your tibial eminence, and we can see it going there. So you want to watch that on all three planes if you can to confirm it's okay. We got more questions coming up here for the group too. Let's see what else we got. Okay, here's your next question. 23-year-old soccer player, acute knee pain, swelling after non-contact injury. Here's the MR that's shown. Which of the following ligamentous injuries is most commonly associated with this imaging pattern? MCL, PCL, ACL, LCL, or posterior lateral corner? So the findings here, I'll point them out before I give the answer. We see a little tiniest bit of bone marrow edema of the lateral femoral condyle. We see the tiniest bit of bone marrow edema and maybe contour irregularity of our posterior aspect of the lateral tibial plateau. How do I know we're lateral? That's a good question. You can kind of hallucinate a little bit of proximal tibiofibular joint here. The meniscus is usually a little bit smaller, but here's the lateral femoral condyle, posterior aspect of lateral tibial plateau. Let's say it's lateral. Hopefully, you guys know the combination of those two contusions or bone marrow edema pattern is called a pivot shift contusion pattern. And the pivot shift contusion pattern has a very, very high correlation with anterior cruciate ligament tears. So ACL is the correct answer. There isn't some association with ACL and posterolateral corner injuries, but that is not the most common correlation here. So again, if you see it, lateral femoral condyle, posterior aspect, lateral tibial plateau, gotta look for the ACL because greater than 90% of the time you're going to have an ACL tear when you see that pattern of contusions known as our pivot shift contusion pattern. So let's look at a case that's going to illustrate that. One thing is we see a buttload of subcutaneous soft tissue edema. It tells us there's something going on. Peroneal nerve, biceps femoris. There it is. We're going to play through. There's the lateral collateral, IT band, lateral meniscus. And we see our pivot shift contusion pattern right here. Lateral femoral condyle, posterior aspect of lateral tibial plateau. And so I'm going back and forth a little bit, and then here we go. As we get there, the ACL is basically blown to smithereens, unfortunately, for this patient. Look at the PCL, it's nice and robust and black and hypointense, as we see here. But in contrast, the ACL, all you see is ghosts of fibers here. You can actually see on the non-fat suppressed discrete disruption of what should be an intact ligament here, indicating a full thickness ACL tear. And so we also want to look for any meniscal tears that can be associated with ACL tears, but we don't see any of that. I see some edema here of the medial aspect of the knee, suggesting that there's a likely MCL injury, which I would confirm on other planes, and we can see that MCL injury quite nicely here. That's thickened, it's heterogeneous, there's adjacent fluid, and that's probably a grade 2 sprain. We'd have to go through the axials to know for sure. But that's what that would be. And we're going to go through these real quick just to see again, ACL should be going from your lateral femoral condyle to your tibial eminence, and there's basically no tissue that's going from here to here. In contrast, you see the PCL that's hypointense, going from the medial femoral condyle to the posterior tibia, but we do not see an intact ACL. So here's another question for you. 30-year-old rec basketball player, intermittent knee pain, mechanical symptoms, twisting motion injury. MRI was obtained. Which of the following best supports a diagnosis of a meniscal tear? Is it increased T2 signal within the meniscus not reaching the articular surface? Is it linear signal reaching the superior or inferior articular surface on two slices? Is it displacement of the meniscus by more than 3 millimeters from the tibial margin? Is it diffuse meniscal low signal intensity, or is it decreased meniscal height with irregular inner margin? Give you a second to think on that one. So the answer to this is B. In MR, we have a two-slice touch rule. Okay, so in order to diagnose a meniscal tear, you need to see linear abnormal signal, which disrupts a meniscal surface on two consecutive slices or on two orthogonal planes. Okay, that is the classic definition. There is some variability to that, but the classic definition, particularly for any examinations you may take, is that. We can see here nicely on this static image that there's fluid signal intensity disrupting the medial meniscus posterior horn. It disrupts the inferior articular surface, and we can see here on the coronal orthogonal plane that it's there too, disrupting the inferior meniscal surface. So that is two orthogonal planes, fluid signal intensity disrupting the meniscus, horizontal tear. So let's see that again. A different case of meniscal pathology. And this is one of the more commonly missed meniscal tears, if I think I put the right one in. So let me just show you here. Okay, so the key here is this. Here's your PCL. If we're going from lateral to medial, your first slice as you exit the PCL, you should see a medial meniscus posterior root. Okay, there should be a triangular posterior root here. All we see is this mashed potatoes, terrible gray looking ghost of a triangle. We don't see a nice robust triangular structure like we do, for example, with the lateral meniscus. So first slice out of your PCL, if you don't see a medial meniscus posterior root, that indicates a radial root tear, which can cause instability of the meniscus. It extrudes into the medial femorotibial recess, and you're going to have premature or accelerated articular cartilage loss in these patients, and they're going to have symptoms of locking and all the classic symptoms, as you know. The ACL is also out in this person just to show an example of like what's probably a chronic, maybe a long-standing ACL tear, because I didn't see a pivot shift, but there's no ACL here. There should be an ACL there, and there's that PCL by comparison. We can see some bone marrow edema of the tibia, telling us that there's some osseous contusions as well. So I want to show you that on another plane, just so you can see on two other planes. I wish I would remember to mute that. So here's on the coronals. Let me show you. So here's our radial tear right there. Posterior horn, we see a fluid signal intensity defect disrupting the posterior root, and that is a posterior root radial tear. If we go to the axials, hopefully we can corroborate that tear. So that's the lateral meniscus where there's also a tear. And then the medial meniscus, we're going to see here that there's a fluid signal intensity defect right there. So we have it in three planes now, but one of the more commonly missed, again, meniscal tears is a radial root tear because sometimes it's like only a 1 or 2 slice finding. So you got to have a high degree of attention to detail to identify that. And let's see, I'm probably going to just pass whatever this is. I don't even remember. Oh, here's another radial root tear, by the way, just for comparison. Here's our PCL. First slice out of the PCL, ghost of a meniscus, and then finally it comes back again. So that is a radial medial meniscus posterior root tear, and you can see that on the coronal plane here on that one slice, and on the axial plane here on that one slice. Here's another question for you. 17-year-old female track athlete, knee pain, swelling after popping while pivoting. MR is performed. Which of the following structures most commonly injured in this clinical scenario? Lateral patellofemoral, medial collateral, lateral retinaculum, or patellar tendon? The answer here So hopefully what you've seen is that here is our lateral femoral condyle with some bone marrow edema. Here's the inframedial patella with some bone marrow edema. Medial patellar and lateral femoral condylar bone marrow edema, that pattern of contusions is most in keeping with a transient lateral patellar dislocation where a patella dislocates laterally, hits the lateral femoral condyle on its way back home, and that gives you this contusion or injury pattern. And when you do that, you stretch out this structure, which is your medial patellofemoral ligament, which connects your medial patella to your femoral condyle. If your patella is all the way out here, that gets stretched out and you get a sprain of your MPFL. And so that is something you want to look for on your transient lateral patellar dislocations. Here's a pro tip. If you're trying to figure out if it's medial or lateral, the lateral facet of the patella or the femoral trochlea is long, lateral, longer than the medial facet. This is not the best depiction of that, but I'll tell you if they give you femoral trochlea, you ever need to know which one's lateral. You don't have a fibula to go off of. Lateral is longer than the medial facet. So here's another sagittal knee MR. We can see big lateral femoral condylar contusion. We can see there's a fracture as well. Here's our inframedial patellar contusion, showing us the injury pattern of a lateral transient lateral patellar dislocation. Again, lateral femoral condyle, medial patella. You can see there's no cartilage here and there's no subchondral bone blade. This black line is disrupted, so this is an impaction fracture. We want to search the joint for any displaced chunks of cartilage or bone, which commonly happen in this setting, depending on how severe the trauma was. Okay, here is that, and then axial plane, lateral is a little bit longer than medial. Here's your contusion. We want to look at the medial patellofemoral retinaculum. Again, it's black. It shouldn't be disrupted by fluid, shouldn't be too thick. And so maybe it's a little gray here. Maybe there's a mild sprain, but nothing crazy. I also want to show you on X-ray, you can see little chunks of bone adjacent to the medial patella. Here's a chunk of bone in the posterior recess of this patient, which is displaced from the patella in the setting of a transient lateral patellar dislocation. Okay, we're nearing the end here. The last couple things I want to talk about are in the setting of a transient lateral patellar dislocation, there's something we measure called the tibial tuberosity to trochlear groove distance. Basically, in an axial image, we find our tibial tubercle where the patellar tendon inserts or attaches, and then we want to measure the distance in the transverse plane of that area to the central aspect of the femoral trochlea. And this is just a very cursory way of doing it. Basically, what I do is I go down to the tibia, tibial tubercle, I keep my mouse there, and then I scroll up. So I keep my mouse here, I scroll up, I scroll up, I scroll up. I see the central femoral trochlea, then I measure this distance parallel to the femoral condyles ideally. And then we know that above 20 millimeters is abnormal. That's an elevated TTTG. And basically, if your tibial tubercle is too far lateral just because of your anatomic predisposition, then you're going to be tugging on the patella lateral biomechanically, and that is going to predispose you to recurrent dislocations. So some folks who have recurrent dislocations can get tibial tubercle transfers or osteotomies to position them medially, so they would be less prone to that reoccurring dislocation. And I think one of the last things I want to talk about here is the association of patellofemoral impingement. So in the supralateral aspect of this fat pad, we call Hoffa's fat pad. If you see edema there, this patient is probably chronically impinging that fat because they're maltracking. And so they may not be dislocators, but even this is like, it's kind of silent killer because you can have accelerated patellofemoral cartilage abnormalities. So this patient may need some PT to strengthen their quad muscles in order to provide some counter traction to bring this patella more central rather than tracking laterally. So look for this lateral Hoffitis or edema in the supralateral aspect of Hoffa's fat pad. Okay, I did it. So a few resources I wanted to tell you guys about. xrayhead.com is a really good anatomy atlas for MSK stuff. It's free. If you ever want to read about any sort of imaging manifestations of a disease, I would say just Google whatever your disease is, plus rad source, the word rad source, it'll take you to this website and take you to the exact link that you're going to want to see to read about. This is a nice link with a bunch of other MR, X-ray, um, interpretation skills from skeletal radiologists. And then lastly, similar resource from musculoskeletal radiologists, which is geared toward radiology residents and trainees, but it could be useful for you folks too. So hopefully this is recorded so you'll be able to see these links online, but I appreciate your time here today. Hopefully you found that useful and looking forward to maybe crossing paths at some point in our careers.
Thank you, Dr. Faraji. That was great. I really enjoyed seeing the T1 and T2s side by side. So thank you for doing that and telling us the T1 is really good for seeing tissue planes, nerves, and also showing us how to measure the alpha angle and the TTTG distance. In the beginning, you talked about how you had the FAI sequence and the hip fracture AVN protocol. Do you ever have anyone order both?
So usually the protocol happens on our end, I would say. So
Mhm.
usually on your end or the clinician's end, they're ordering an MRI of the hip or MRI of the pelvis. And then on our end, we have, fellows or technologists who are then picking the correct protocol depending on the clinical indication. Sometimes it's a little bit more ambiguous and we may reach out, or sometimes like arthrograms are ordered inappropriately by some folks, so we'll call in those cases to make sure that's what you want. But yeah, you don't have to worry so much as to. I guess there are instances where you may specifically ask for a 3T or you may specifically ask for an FAI protocol just to make sure the wrong protocol isn't performed. And in our clinical setting, basically, we'll just say put in the MR hip and then in your comments type in 3T FAI or 3T labrum or just anything labrum should get you the small field of view. At least that's how it works with us. So.
Okay. And you talked about 3T versus 1.5T arthrogram. I-
Mhm.
Is there also 3T arthrogram?
There is also 3T arthrogram, which is probably the best of both worlds, I would say. The only thing you have to know, though, is that the arthrogram protocol does not have many fluid sensitive sequences. So contrast when we inject in the joint is only bright on T1 sequences. So we can see the contrast in the joint and we can assess the labrum, but the arthrogram protocol is not going to be as good for tendinous pathology or anything like that. So if you're not sure that it's labrum or it's maybe more non-specific complaints, I would say probably non-arthrogram, regular 3T is the move. But if you're pretty sure it's labrum, yeah, 3T arthrogram is probably better than 1.5T arthrogram in that setting.
Okay,
Yeah.
great.
Cool. Well, thanks again for having me and good luck everybody in your future careers.